We have a great panel tonight. We have Billy Harvin from Texas and Kyle Mobley from Florida. And amongst the group, including myself, we have about a combined experience of 600 implant placements and almost 460 patients. And, roughly we've had to remove about 3% of these devices, which is relatively low. But you have an experienced panel tonight. I'm going to give you a brief overview on some general knowledge regarding nailing and some history that I think is interesting and pertinent to hardware removal. And then we'll turn it over to Dr. Harvin and then followed by Dr. Mobley to discuss some specific cases and their innovative techniques to removal. And I think that's the one thing to remember here is that techniques for removal evolve over time. And with that, what I would tell you is that if we look at the history of IM nailing, it's hard not to talk about Gerhard Künchner, who really performed the first nailing sometime in the late 30s, probably 1939, in Kiel, Germany. And he presented his initial results at the German Trauma Society meeting of 11 femurs, one humerus, and one forearm. So, I mean, he looked at a broad area of nailing. And frankly, the response to that, with the exception of his leadership at his home institution, was hostile, and he was essentially ostracized from the community. Eventually, he found his way during the World War to Finland, where he was a surgeon in the German army, and he got approval from the army in 1942 to practice what they called then was the marrow nailing method. He practiced it equally on German soldiers as well as primarily downed Allied airmen. Um, and he had pretty good success with that, but it did not come without problems. And one of the problems that they had was because of the mechanical and interference fit of the nail, sometimes it would become incarcerated, unfortunately, halfway down and halfway out. And Kunstler was smart enough to know that bone resorbed around the nail, but like all good innovators and good surgeons, he didn't let all of his secrets go, but he would simply tell the referring surgeon who was practicing his technique to simply put him on a train to his center, and he would solve the problem. And all train rides in wartime Germany took 3 days to get somewhere. And by the time they arrived at Kunschner's center, he could easily remove the nail or pound it in because the bone had resorbed or the nail had relaxed enough to allow that to happen. So nailing problems, removal, incarceration, etc., is nothing new. And when you really think about modern nailing in North America, we have to thank Robert Winquist from Seattle and Harborview for popularizing the technique, primarily 40 years later in North America, where it started to get acceptance in the early 80s. But part of that was the same problem. These nails occasionally, despite their reported high union rate in over 500 cases, they still had problems. They had nail failure, non-unions, et cetera. And Dr. Winquist, over time, thought a lot about nail removal, and he's left us um, with innovation and tried to coordinate amongst implant manufacturers a standardized way of removing the nails. That was ultimately unsuccessful, but most of us are familiar with what originated with Snap-on Tools, which was a universal nail removal set that's now manufactured by the Shukla company. And the techniques for nailing removal have continued to evolve with traditional nails, which have changed over time. And I would submit to you that as we talk about IlluminOss nail removal, this is not really a new problem in intramedullary nailing. Every single nail advancement has required some sort of innovation for nail removal, and we're in a situation now that's really no different. But Kunstner nails had to be removed a certain way, had certain problems. The introduction of titanium nails and the greater adherence of bone caused problems. Solid nails left us with no cannulation to capture the nail. Different techniques had to be developed for that. Trochanteric entry nails or old tibial nails with double bends that are asymmetric create problems and mismatch with the canal for removal, again, requiring techniques or even in some cases failed removals. Flexible nails, retrograde nails, expandable metal nails, they've all presented challenges for nail removal. And so With that, IlluminOss is no different. It's still an intramedullary nail, but of a different design and different capabilities. And with that, we're going to have to think about new ways for removal. The nice thing about the IlluminOss device is that the acrylic monomer that consists and gives its rigidity is contained within the sides of an inert balloon. The acrylic doesn't interdigitate with the bone, and the balloon does not adhere to the bone, and the bone has no affinity for the balloon. So there's no actual binding between the balloon or the acrylic and the endosteal surface. We can drill into the implant, which means in certain situations we can retain the implant and use it as an augmentation, particularly in poor quality bone. And because you can drill into it and screw into it, it gives us an easy way to capture the device to remove it. And IlluminOss has provided us with some removal kits that are built on this knowledge that we can drill into it. The nail remains cannulated, though the cannulation is small. It's preserved by the optic cable that goes down the center of the nail. And you can simply slide a small K-wire in there, or you can interdigitate a threaded wire. And then you can use a cannulated trephine or drill that's provided in the set to go over that wire to enlarge the entry point to accommodate the largest part of the nail, which is might be an issue if you're using an asymmetric inflating nail where the top of the nail is bigger than the bottom of the nail. You see here an illustration of how that might work. You cannulate the nail with the K-wire or the threaded rod. You put the trephine over the top of it to enlarge the exit point, and then you drill into the device and simply put a threaded extractor in there and then slap it out. So you can see these sets here on the next page, two different sets for nail removal, the trephines and the drills. The cannulation is helpful. We've worked on that in the lab. There's ways to enlarge that cannulation over time and thin the nail out, and that might be one technique for breaking the nail up and removal. Ultimately, here's just a quick example of a humerus. You can see the wire threaded into the nail, the trephine entering the bone, enlarging the exit point, the threaded extractor going in over the wire, and eventual extraction. So ultimately, what nails need to be extracted and what nails can be retained. So retention is generally preferred. It's easier on us, easier on the patient. And that really requires a situation without infection and where the device, for whatever reason, is not going to interfere with the new implant, particularly a plate. If you are planning on doing a different nailing, or if you're planning on inserting a joint replacement of some sort, then nail retention may not be possible. And that's where extraction's involved. If you need to do a joint replacement and the nail's going to interfere with your device, it clearly needs to come out. Certainly, extraction with joint replacements at the proximal humerus or distal femur should be relatively easier. And then unresolving infection, you can't attempt to retain the implant in the face of infection like any hardware, as long as it's functioning appropriately and the infection can be cleared or at least managed and suppressed. Otherwise, if you have recurrent infections, then that creates a situation where the nail needs to be removed. I can tell you one other technique that I would recommend if you are experiencing the need to extract a nail is I met Bob Winquist when I was back in beta or Charlie year of my practice sometime in the around 2000, I think, and I talked to him for a while, so I knew him, and I encountered a nail that I'd never seen before, and I needed to remove it. It was the early days of the internet. I took the time to take some digital photos. I emailed them to Dr. Winquist, and within days, he knew exactly what kind of nail it was, and he gave me very detailed instructions on how to remove it. So while we'll talk about specific techniques here, sometimes there's no reason not to reach out to someone with some experience with the device. I know our panelists tonight would be anxious to take a call if anybody had questions regarding removal and their experience. And you know what? I did exactly what Dr. Winquist said, and it was one of the easier hardware removals in my career. So with that, I'd like to turn it over to Billy Harvin to show us some cases and some novel approaches for nail removal.
My first case was in 2021, so relatively early adopter of the technology. And now. I've done just over 230 cases. Multiple of those have been with multiple balloons. Um, and to date, so now about 4 years, I've had to remove nine total patients. I would say that there's a bit of a learning curve to this technology, and that almost all but two of these removals were from things I did in the first year, and really almost all within the first 2 years. So in the last year or two, I really haven't had to remove much just because I feel like I have a better understanding of indications, techniques, and what's going to work or not work. And this was me during my first removal, like, what the hell am I going to do? To Steve's point, some hardware removals are daunting, but we just got to work our way through it and find different solutions. And so I'm going to go through three cases, and we'll show some different techniques. And the way I break it down is, well, why does it have to be removed? Is it failed fixation? Almost always, in this circumstances, we're talking about proximal humerus or distal femur. And like, what's the next step? What are we going to be converting it to? In the humerus, we're probably going to do a conversion to a total shoulder. Sometimes we may revise the ORF if it's salvageable. In the distal femur, we're going to do a distal femoral replacement or potentially a stemmed arthroplasty of some sort. Non-union situation, does it even have to be removed? Sometimes, even though it's not providing stability to the fracture non-union, it still gives stability to the screw fixation. And in my opinion, and when it's infected, just like anything else, for the most part, it's going to have to come out. And the other thing to think about is this early? Is it late? How mobile or stiff is the construct? Because something fairly early that moves around is a lot easier to take out than something where there's almost, whether it's completely healed or partially healed, and that's going to take a little bit more work. My go-to implants are just threaded Steinman pins. I don't always have the extraction set in the hospital, so this seems to always be available. Those can be threaded into the top and back slapped out. The other one's a Moreland set or a cement retraction set that has drills and taps that can also be screwed in and backed out with pituitaries to grab onto longer uh, buried implants, reverse curettes, because this, unlike the metallic nails, this can be destroyed and then the remnants can be removed. This is the extraction set that Steve showed with very similar technology, coring reamers, drills, and taps. And then the last thing is a saw. A lot of times in the proximal humerus, we're just going to cut the top off with a saw, and I'll show some cases where I make corticotomies to take out well-fixed balloons. So in the femur, this is one patient that unfortunately I treated his initial fracture with a retrograde nail, and he didn't heal and went on to repair his non-union with this technique of intramedullary IlluminOss and lateral plating, and this didn't heal. And he was still complaining of pain 5 months post non-union repair. And he's got an arthritic knee. He also has some chronic pain issues. And is this a partial union or a persistent non-union? And it's hard for me to kind of figure out which one of those is the source of his pain. No, I didn't fix it in varus. It just displaced in varus. Since this is a flexible fixation, it did fail into varus over time, and the guy's a large guy. So in retrospect, maybe I should have stuck with a standard nail plate combination for him, but this was my hope that would work. You can see that there is some attempt at healing. I'm not going to say it's healed, but it's probably still a hypertrophic non-union. And so our plan was to convert him to a stemmed total knee arthroplasty so that we could solve two problems. One is his potential non-union, the other is his arthritic knee. And here's where we started working through the knee joint, Steinman pin. It doesn't interdigitate, it doesn't have ingrowth, but I was trying to work around the implant and use this coring reamer. And once we got the bottom half out, since it was curved, I have to take a different route through the same area, threaded diamond pin, drilling with a tap, ultimately drilling past the balloon with a drill and then reverse curette. And ultimately, we're able to get the whole thing out. My arthroplasty partner comes in and starts templating him for a stemmed knee arthroplasty. And that ends up going on to healing. He actually came back for his other knee replacement for my partner. So this guy went through a long time, but ultimately he had a successful result. This is a more complicated case, in my opinion. This guy had a distal femur non-union below this hip replacement. I went back and repaired his non-union by medial plating and bone grafting. And he was doing great for 7 months. Great. It's the best he's been. Unfortunately, he comes back with a draining wound medially. And we can see on this image that the sinus tract goes directly towards the posterior aspect of the femur. And now I'm like, crap, how do I get this out? And so um, my plan was to make a corticotomy. And if you think about this, I don't think I can just thread something in the bottom and pull it out, given its variable size. Plus, there's actually two balloons in this gentleman. So I cut here and create a rectangular corticotomy that was probably about 6 by 3 centimeters. And I cut the balloon again like this. And at this point, I'm able to take out the top and the bottom by threading stymon pins out. And then I can use this window to access and debride the rest of the intramedullary infection with curettes, ultimately going on and putting a boatload of antibiotic beads and spacers in. And this cleared his infection. You're going to be able to see the corticotomy on this right CT scan right there. So this guy's over a year out now. His cultures were negative, but we treated him for several months with antibiotics, and he's walking now, no pain, and off antibiotics. And then last is a tibia, kind of similar case. This guy, older gentleman, came to me delayed in an external fixture. When I attempted to fix his tibia, his screws really didn't have great fixation, so I, on the spot, kind of turned to saying, "Hey, let's supplement with IlluminOss just to improve my screw fixation." Ultimately, about 2.5 months out, he was having increasing swelling and a little bit of redness. Put him on antibiotics for a couple of weeks. It got better. Came off antibiotics. Symptoms came back. So it's kind of clear that I think this is infected. And his white count and his inflammatory indices were elevated. I got this CT scan just to see how healed it was. At this point, I do see some signs of healing. It's difficult to say whether this is periosteal reaction from infection or is this callus from the healing. Although, I mean, it was a primary bone healing attempt. Um, and I basically did the same thing. I went back through his posterolateral approach, found the implants, took out all the plates and screws. And then through that, you could see the balloon through a small defect in the fracture site. And I just made a little trough with a saw, and I took out the central segment of the balloon and then used diamond pins to pull out the top and the bottom. Completed his debridement with an antibiotic-coated temporary nail, and then came back a few days later and did an antibiotic-coated locked nail. And ultimately, he healed. And since then, he's over a year out now. He's undergone implant removal in preparation. With his RA, he's got a very bad planovalgus foot. So he's getting prepared for his foot treatment and has actually had his right contralateral right knee replaced. So lots of different techniques to get this out. We always get asked, can it be removed? Yes, it can be removed. The question is, does it need to be removed? In many non-unions, it can be retained. Even in some arthroplasties, if you're just doing a stemmed arthroplasties and your balloons are off axis in the metaphysis, you just drill through the diaphyseal portion and you can retain some of it as well. certainly in infections or when it is a space occupying lesion that you need to convert to an arthroplasty, those need to come out. Just remember threaded stymon pins, drills, taps, reverse curettes. They do have an extraction set. Always can open the cortex with a saw or a burr. To date, I've taken out 9. Unfortunately, that's still pretty relatively low failure rate. And then every time I've wanted to take something out, I've gotten it out. So that's my experience, and I'm happy to take questions when Dr. Mobley's done.
So similar to Billy, do want to stress that this can be removed. I've put in about 150. I've removed one of mine, but then I'm not the only guy around doing these, so I've actually removed a few more from other providers in town. So the this first lady, this one was from one of my partners. This 79-year-old lady, ground level fall, displaced, and also similar to Billy, I'd like to stress that most of these failures have been from our first year. I've been doing these for about 4 years, and so we did some things that we know aren't optimal now. And so this lady was fixed just percutaneously with a single entry point and and a single balloon with no plate or screw fixation. And I don't have the post ops here, but she looked great post op, and then the head just slipped off the top. So for her, we had a discussion, and the goal was to go to reverse. So when we got this out, so here are the all the tools I used, and for my extraction and as well as my insertion, I start with just a 3-2 guide wire from cannulated screws, and for the extraction, I put a T handle on that and back slap it out. So uh, here's just a video of once I've got uh, the wire threaded on. Cocked my assistant there in the head. Um, and so here's what it looked like with the humeral head kind of slipped off the top. So this is what you're looking at. Benefit of the proximal humerus is once you do get rid of the proximal humerus, it's conical where it narrows going away from you. So you don't end up with nearly the difficulties as the distal femur or some other places where you can get it wider in a distant portion. And it's pretty straight also. So I actually just cut off the top. You can cannulate this tunnel from the fiber optic cable, but sometimes that can be a little bit difficult with a rounded end to get right on it. And so I just cut off the top so I could see that really well with a flat surface. And then I cannulated it with that 3-2 guide wire and was just able to backslap it. Just like anything, you can see that it took a few hits, but like was emphasized before, you don't have the ingrowth. So this is kind of press fitted inside, but not interdigitated and not ingrown. So once you get it moving, usually it comes out fairly smoothly. We converted her to an arthroplasty. Similar case. This lady was really a pain control issue. She just begged me over the course of 3 weeks to do something, even though this is something I would typically treat without surgery. And she just couldn't tolerate it. And so once again, we were in kind of a little bit of the early stages of using this. This lady, I did try to put an interlock in proximally. So you can see my immediate post-ops on the left. And then I actually rode this out for over 6 months, where she would come in complaining of pain. It would still look good. And and even initially made some callus and then turned into this non-union and actually displaced. And you can see the screws penetrating the head there on the far right. So then agreed to go take this out for same instruments, no different. This time I did cut the top of her head because she actually had enough callus and scar tissue around there to have a stable fracture site, even though it was painful. So I made a typical cut, and then here is after we actually had it out just a little bit. This lady had a massive canal. I think it didn't get as good a fill Um, and so coming out a lot smoother. And then have a bonus video at the end where one of my partners put one of these in for a guy that was basically on hospice and it got infected. And I was able to remove that with just a rongeur because it was just not pressurized as well as some of the ones I do. This lady then went on to, fracture distal to the implant with a supracondylar. So she's been a recurrent patient of mine. Um, and then here's another proximal humerus, similar problem. We had a trial of non-op, and at 2 weeks, she just said, "You've got to do something. I can't take this." This was more recent. This was actually in January of this year. Um, so now this is what I'm doing for these. So sorry, we don't have a good post-op picture here, but um, I'm doing an IlluminOss, but also reinforcing it with a plate, and I haven't had any failures of that. So you ask, why is it in this talk? Well, she goes and breaks distal. She shows back up into the ER a couple months later, and they call me with this. And so, even though this is a removal talk, I did want to emphasize, just like the past two guys have, that it doesn't necessarily have to be removed. This isn't like, if you have a nail here, then you have a big problem. But with this, I just reduced it. You can actually drill, place lag screws through it, and then I just plated right on top of it. And the benefit there is you actually get amazing bite on your screws with these osteoporotic patients. So just keep in mind that it doesn't have to be removed. And then here's this other guy that got infected. And like I said, if it's not pressurized super well, all I needed for this was a rongeur.
Well, one of the questions that came up that I know Dr. Harvin answered on the chat is, do you notice anything in the infection cases, Kyle or Billy, that as it relates to the implant itself? Do you see abscess formation? Does the implant come out easier because of bone resorption?
That could have been another reason the infection one came out earlier or easier. Looking back at his initial CT scan from his trauma CT, he had what went completely unread, but he had either a hematoma or already an abscess on his chest wall. So this guy had, it migrated from there to his IlluminOss, I'm pretty sure, and he had an abscess all down on his chest wall up in his axilla. But around the implant itself, it just seemed to be a little film. Um, nothing crazy around the implant itself.
Other than the cases I showed, I had one proximal humerus maybe a year ago that was infected, and happened about 6 weeks out. It was pretty clear that there was actually healing, but the lateral cortex was open, and it was easy, just like Kyle's last case, just to grab the thing and pull it out. And then at that point, it's just debriding infection like you normally would, curettes and all that sort of stuff, rongeurs, and then I went back with an antibiotic spacer. It's different than most metal implants that you got to take out as a complete unit. This, if you can't get it out just by backslapping, you can destroy it. So I can drill through it, and then I take reverse curettes or pituitaries, and I grab it, and I just start cleaning it out, just like I'm cleaning cement from, a revision total hip or something like that.
So we have one question for the panel. Have you seen any cases that have failed from what appears to be hypersensitivity to the material? Some sort of
No,
allergic reaction or anything like that?
No,
no.
in fact,
And I broke. Go ahead.
no, go ahead, Billy.
No, I broke in many balloons, and that's when you would suspect that if this was a monomer, had some sort of allergic reaction, you'd see. I broke in at least 10.
Another question, particularly as it pertains to perhaps removal from a rami. The question is do you think an aggressive shaver from an arthroscopy set would help break that up?
I've had one partner go back for one balloon early on that as the proximal humerus, the fracture settled a little bit. That was before I was using almost exclusively plate IlluminOss combination, is that you could see a little bit of settling of the proximal humerus, just like you would any other proximal humerus fracture, and then the balloon stuck out of the top. And we went back and shaved that down arthroscopically. So yes, it can be shaved arthroscopically.
I wanted to just kind of go around the panel just to say, what's been your learning curve with this? Where do you think it's optimally indicated? What kind of combined constructs do you feel we should be using it with? And where might it be standalone besides just the pelvis?
I mean, I personally think if you fix proximal humeruses regularly, whether you believe in that or not, certainly there's people that don't. When you start fixing them and you have what I think are pretty good outcomes, I personally think it's game changing for that indication. There's obviously other endosteal support techniques, whether they're calcium phosphate, fibula struts, that sort of thing. I have plenty of partners that are big fibula strut users, but that is quite complicated. Certainly it's doable to displace a fracture, insert the fibula, reduce it. Oh, I don't like the shape, re-displace the fracture. There's a lot of whittling going back and forth. In this technique, you put the wire right where you want it. I mean, right where you want it first time, and you inflate the balloon, and it's money every time. And so this, for this one indication alone, is game changing. The other things that I'm doing a lot more are like geriatric ankle fractures. If I do a reduction for, say, a geriatric trimalleolar fracture, and I put in my lag screws on my fibula, and there's just no bite. Next thing I'm doing is like, okay, pull the IlluminOss, and while I'm clamped it reduced, I'm putting in an 8x80 or 8x100 an inch medullary canal. Then I'm putting my plate on top of that. So I think it's augmenting everything I'm doing in that population, that geriatric population, which is, almost half of my patients. So that, for those two things, it's been pretty game changing.
Kyle, standalone option. Does it
Yeah.
exist?
The only things that I currently use it as a standalone are in the pelvis, for percutaneous pelvic fixation, and I'll use it occasionally on a distal fibula with a distal tibia fracture. That is, I can kind of percutaneously get reduced and just thread this up in patients with. I'm just like Billy here. I got a ton of geriatric patients, a lot of people with terrible skin or super swollen, and just want to make as few incisions around the ankle as possible. And sometimes I'll just snake one of those up and inflate it to give them some lateral mouse stability.
Yeah, for myself, the standalone is the superior ramus for a lateral compression pelvis. I think is probably the number one place for a standalone for me. The second place would be a person with metastatic disease and a pathologic humerus fracture that's diaphyseal seems to be a little bit easier on them and will last at least for the remainder of life in the few instances that I've used it there. Um, there's a question. We'll take this one final question, and I think in the interest of time, we'll wrap it up. But can you comment on the cost for geriatric patients with IlluminOss versus standard plates and nail? Will my hospital notice the cost? I'll take a stab at that one. I would say definitely the implant adds some cost to the geriatric patient, but at the same time, I don't think it's cost prohibitive if you're considering the use of a standard nail plate, metal nail plate combination. I don't think you're going to exceed the cost of any combined implantation like that. Obviously, remember the most expensive implant is the implant that doesn't work. So in the geriatric patient, that can be excessive. And as it relates to distal femurs, you're looking at a big cost differential for particularly for some fracture patterns like distal femurs, where you're considering a DFR versus fixation. The implant costs of a distal femoral replacement are far exceed most anything we can do with internal fixation by probably 2 to 4-fold, depending on the implant. Thanks for answering all the questions. Great presentations. Super innovative and how you guys are taking things out. And it's always good to get a group of people together that'll show their failures, because that's not always so easy. So, but that's where the experience comes from. Thanks, everybody. I hope you enjoyed the webinar. And if you have more questions, please feel free to send them in. We'll try and get back to you one way or another.